Hey guys, you're watching the Best Practices Show, where we take a look at the best business practices from the best dental practices all across the country. And when you're building a great restorative practice, one of the things you're looking to do is to build more trust. And a key way to do that is through the exam and records process. And I've got one of the world experts on this, Dr A Cobb, who is one of the directors of the core curriculum at the Dawson Academy and lead faculty. Do not miss this. Do me a favor. Grab a pen and hit the share button. We'll see you in a second. Hey guys, welcome back to the Best Practices Show, and I hope you're having as much fun as we are. Crazy grateful that you're watching today, and love all the requests that you're getting, and we're doing our best to keep up with those requests, and today is no exception. I have got an incredible leader, mentor, and educator on great restorative dentistry, and you are going to love this. So I just want to say thank you. Also, we are shooting this live on Facebook, so this particular episode, while you're watching this during the live feed, if you have questions, add them to the feed, and I'll ask Drew himself, and we'll get the answers straight from the master. Or if you're watching this later on, add the questions to the feed, and we'll continue to add feedback and responses. So we hope you're getting the most out of this while you're watching these particular programs. And also, too, if you're enjoying this, keep doing what everybody else is doing, hitting the share button. We're now up over 16,000 followers in 3 months, 250,000 views per week. And Ben just informed me this morning, we have over 10,000 of you that have followed us on iTunes or found your way to iTunes. So I don't even know what to say. Just crazy grateful, and again we're having fun, but we want to do the things that you guys are wanting to talk about. Now, my good friend who's on today, I'm going to talk about him because I've gotten to know him over the last couple of years, and I've just enjoyed him so much. Very practical thinker, wildly entertaining, great guy, Dr. Dr A Cobb, who is one of the principal people down at the Dawson Academy. Now, Drew, I know who you are. But if people don't know who you are and know a little bit about your story, can you tell us where you practice, how you got involved with the Dawson Academy, and then we're going to jump into the good stuff here.
Yeah, Kirk, again, great being here with you again. We had a blast last time, so I look forward to this again with you. So my story we kind of told last time we got together. But, I graduated from Georgetown in 1984, practiced. My dad was a dentist, went into practice with him. But after practicing a while, just kind of was frustrated. There's got to be a better way to do this. And that's what led me down to the Dawson Academy. And I went through all those classes, and I was just driven to change the way I practiced dentistry. So I did, all the hard work. I probably made every mistake you can make trying to take those techniques and put them into practice. And gosh, for the last 8-9 years now, I've been associated with them as faculty. So it's been kind of a cool ride. But I got to tell you, this is the best way to practice dentistry. It's changed my life as a dentist, and actually for what I can do for our patients too. It's really fun. It's great to get up in the morning and go to work. I love it.
Yeah. What's really cool about you is you're a good guy doing amazing dentistry, and you got a great practice life balance. And last time you were on, you shared with us, I'm a big fan of the 7 to 3, but you work 7 to 2, which, yeah. And we were joking before we got on, you're like, summer's here. I'm like, it's always summer by you. You're always working great hours. So, just further evidence, dentistry is a great life if you're really intentional about it. So, gosh, I'm crazy excited. Now, this is such a hot topic and such a critical piece. The cornerstone, as you're going to share with us. Yeah. Now, tell us why this is so important, though, because we're going to get into the details of this. Why is the exam and the records process so important in building trust?
Yeah, so I think you have to kind of look at the big picture here a little bit. So in the end, whatever's going on with our patients, we have to have a way to identify problems, what's going on, find solutions, and then present that to a patient and ultimately get them to sign up for treatment, right? That's kind of why we're doing what we're doing. Right. And a lot of times I was originally doing a lot of my quote unquote case presentations, right after the treatment planning, and patients weren't part of the process. And you can get in a lot of trouble in a hurry, because some of this dentistry can be expensive. And if you sit down and try to present this extensive dentistry plan to a patient with a big expense, it doesn't go over so well sometimes. I mean, I think the trust patients have in us is incredible. Honestly, to let us do the things that we do, and maybe a patient hasn't even known you that long, that's incredible. Mm-hmm. What we've learned over the years is what I learned from Pete Dawson, is really the trust is the big part of us getting to the treatment plan. He's talked about forever about we're the advocate for their dental health. And if you go about it that way, treatment planning isn't about selling anything. We're there to help solve the patient's problems. And so we're their advocate for health. It's a totally different way about going through the treatment process. And nowhere does that start sooner than the trust issue in exam and records. So the examination that we do on them is what kind of identifies problems. We get to talk signs and implication, what happens if things don't get corrected. Patients get to see that. But so part of that examination is the patient's part of it. So you don't do this examination and they don't hear anything that's going on. We explain what we're doing and why. We tell them what we see, what's going to happen if treatment doesn't happen. And at the end of this, you really want the patient to say, listen, I'm here to solve your problems. You want me to help? You get the yes there. So they already know that there are issues that we're going to look at and try to solve for them. And that's the records process. Treatment planning is so much simpler if you do the records and the exam process the right way.
Right, right. This is such an important I love this subject because if you're a young dentist watching this, there's no shortcuts. Yeah. Trust is the foundation for all relationships, whether they be in a practice or at home. And there isn't a shortage of trust in this world. There's a vacuum of it. And what a great opportunity you have as a dentist to really just slow the process down and do it the right way. And the other thing I'll say about you guys, and specifically you, Drew, is you guys aren't winging this. There's a very systematic approach. Yeah. You guys are big fans of checklists, decision trees, and you're going to see a lot of this. This isn't just made up. And the seminar model is broken, where you go to a seminar and somebody goes blah 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 blah. Right. You really have to go to a course and really have to learn from a master a systematic approach. And you're going to walk us through this. And so Absolutely. you've got a whole bunch of different components on this. So where do we start?
So let's bring up the first slide. So this is just kind of the overview of the process, something Pete's been talking about forever. So this is that process of complete dentistry. And there's kind of 4 pillars to this. So if you look at that first slide, it starts with the exam and the records process. The second one then is, once you get to that, well, now what the heck do you do? Right. So that goes, and that gets to those checklists you were talking about. We have a 2-dimensional and a 3-dimensional process that's going to honestly help us identify the solutions to the patient's problems, kind of in our mind, and then 3-dimensionally with the models. That gets you to the treatment plan. Then the next 2 steps are doing the treatment. Especially with extensive treatment. How do you know that the solutions that we're picking are the right ones? We're going to go for a trial run. We're going to test drive it in the patient with our prototypes. Right. So we like the word prototypes, not temporaries, because by the time we got to that, we've already put in a lot of time and energy. And we can make really great prototypes that are going to solve aesthetic issues and functional issues, but we're going to make sure it's right. And then once we have that's right, we're going to use that to go to the laboratory so that our definitive restorations are replicated by what we've already proven in the prototypes. So those 4 steps, from exam, identifying problems, coming up with the proper solutions and working through that, proving it functionally and aesthetically in the prototypes, and then getting to definitive restorations, that's when the process works well. Now, we're not taught to do this originally. We kind of go from 1, looking at issues, straight to definitive restorations. I mean, that's how I was taught. Right. And you know what? Hey, it works sometimes, but sometimes it doesn't. And when it doesn't, it's a really bad day. Right. We're not doing, we don't want unhappy patients. We don't want things to fail. You don't want to come in Monday morning and some of those restorations that we just did are in the patient's hand. Mm-hmm. So, we like long-term predictability, functionally and aesthetic results that are going to last for a long time. That's kind of the way to build your practice. And that's really what changed my life as a dentist, really, was that predictable solutions that we're able to provide. That's what I was missing on patients. The other key, Kirk, is that this isn't for every patient.
Right.
Some patients, the way we were taught in dental school, go around the arch, this filling's okay, this one needs a crown, this needs a whatever it's going to be. That's okay for some patients, but for other patients, it's not. So the dilemma we have as a dentist is, well, which ones is that process okay for, and which need a different process? And the only way you're going to be able to tell is to do a thorough examination. Right. So it all starts at the beginning.
Yeah. A big piece of this is having the dentist realize the value for this, because the second the dentist devalues this or doesn't completely it all falls apart, because you're going to have a hard time convincing your team members and patients of that. Would you agree?
Absolutely. And, there's a paradigm shift, I guess. So a lot of us treatment plan out of hygiene, right? Patient comes into hygiene. You come in and for what, 5 or 10 minutes? Your hygienist is supposed to identify problems. We set them up at the front desk. They're on your schedule, and you go. And that, again, that's okay for some. But for other patients, you can't treatment plan them in 5 minutes like that, because you really don't know what the problems are and what you're trying to do to solve it. In fact, we might be trying to solve things, but we're not fixing the cause of the problem. So now we're just perpetuating the problem. And now we've put our restorations or our treatment in harm's way. If teeth have worn out and you've lost the enamel or the outside covering on the tooth, and we put a restoration in it, ceramic, what's the risk to our restoration? It's going to break, or the tooth is going to get loose, or there's all kinds of bad things that are going to happen. Mobility, sensitivity, migration, recession, abfraction, all kinds of things that can happen. So we want to find out kind of the cause of the issues. Now we know best how to fix it. And you just got to kind of slow down a little bit, get a thorough examination, get the proper records, sit down with those records, and that's the puzzle. This is what I think is really fun. Once you get that, that's the puzzle, put the pieces back together. That's the plan for the patient for long-term health.
Absolutely. Can I throw an objection at you right away? Because I believe I'm so on the same page as you, but I hear this from young dentists all the time. Yep. Look, I totally get it, but I don't have time for this. And can you give us some perspective on, when do you do this? How long? What part of your day? Take us in a day of your life of what an exam. How much time do you put forth to this?
And it's a great question. And I think, we talked a little bit at our last segment we were talking about, the dentist, you have to kind of figure out what's your vision for your practice, your team, your life. So somewhere in there, you got to figure that out. And I get that if you're in a practice that you're seeing 30 new patients a day, and I'm going to sit here and tell you, oh, you need an hour for every new patient. There's not enough time in the world for that. Right. But somewhere you got to start picking those patients that maybe are in your practice already, and maybe things are breaking down. Maybe something that you did failed. Maybe they're coming in on an emergency and something broke. And those are patients that they've been in your practice. They already know you and trust you. Just those are the ones to start with. Take time and schedule them for a thorough exam. I'm going to say about an hour. Okay. I like to do my initial exams on a new patient maybe first thing in the morning. You don't want to be late. I don't want to be doing other things. I normally just work with one hygienist, but hey, a couple times a month, we have double hygiene. I don't want my new exam in those times. I want to be able to sit down, have a dedicated hour with that patient that I'm not up and moving around. Okay. So one is pull patients from within your practice that already want you to solve their problems. That's pretty easy. Mm-hmm. So now just get the info that you need and come up with the proper answer. Yeah. Others are, and again, this is how do you want patients to enter into your practice? And again, you got to figure out how busy you want to be. This model that, we're following, Pete's model, he's talked about 12 to 15 new patients a month. That's it. Right. And he said, when I first heard this, Kirk, years ago, I honestly, I didn't believe it. Mm-hmm. 12 to 15 new patients a month. That's all you need. And you're going to be busier and have more dentistry than you can do. Yep. And you know what? I mean, I've been doing this now for 20 some years, and that's exactly right. Now, those 12 to 15, as I mentioned, some of those quote unquote new patients come from within your practice. Those are the ones you're going to kind of convert to, for lack of a better word, that complete patient. Right. And others are going to be ones that are maybe they're going to talk to that patient now that you've solved their issues, and they're going to go tell their friends. Now their friends are going to call. Take an hour with those new ones that come in. Right. So that's how you're going to slowly build. And we talk about this kind of this general patient and specialty patient. We'll get to that in a couple minutes. But where most of us start out at dental school, in that, I'll say, usual, customary, reasonable, tooth-by-tooth dentistry, that's the general patients.
Mm-hmm.
What we're talking about is the patients that need a different process because things are wearing down prematurely. There's a different process to figure out what's going on with those. Those are the patients we're talking about. So kind of within your own practice, you kind of build this specialty practice. And those are the ones you got to kind of take through this exam process. So you could still have a high volume thing and run things through hygiene originally if that's how you need to do it. But what you need to do then is maybe train your hygienist, and when you come in, to start looking for some of these signs and symptoms of this specialty type of patient, and then appoint them when you have more time to do the exam. Yeah. And nothing we're talking about, Kirk, in this exam is earth-shattering. You know, right. I mean, it's like you go through and say, oh, you know, hey, it just makes sense. It's just that we never do it or put it together or take the time to do it. The exam process we're talking about is an hour. I mean, that's it. It's not a 2-hour thing, you know, but you just got to do it. And it's in addition to what you're already doing, meaning everybody out there, they're doing periodontal probings, they're doing the bacterial checks, looking for decay, radiographs, all that sort of thing. So we're talking about this TMJ occlusal functional examination on top of that. And, you know, we just have a checklist to go through it so that you don't miss anything.
Yeah, this is so good because I found what you said to be absolutely true. You don't need 30 a month. You don't need 50 a month. You need 12 to 15 highly qualified. Now, think about this. If you're a dentist watching this, that's about the number of days that you work per month, maybe 16, 17, 18. You know, if you're working 25 days, 30 days a month, you're working too hard already. So when you simplify your life, you're talking to one person that's qualified per day for an hour. And let me just say this, in an hour, it's hard to get to know somebody. I mean, you're just scraping the surface. And Drew, you guys taught me this. I think we're gonna talk a lot about the mechanics, but what's more important than the mechanics of that particular exam is the connection piece, because it's real easy to put all of these things in a patient's mouth and start gathering data. But you got to remember, there's a human being right here.
That's exactly right. You know, so bring up the next image, because again, something I learned from Pete is the first part of this process is what we're going to refer to as the preclinical exam. So when a patient first comes into your office, and I know you talk about this with your clients, you know, how a patient enters a practice, and, you know, from the initial phone call to everything. But when the patient actually gets to your office, how do we first meet them? You know, is it in the operatory, where they're laying back in the chair, mouths open, and we come in and we start rattling stuff off to our assistant? You know, we need this, we need that. There's a big restoration here. This one has decay. There's no connection at all. Right. So the way that we do this with this, what we call this preclinical exam, is I like to do it out of the operatory, if you're able to do it the way your practice is laid out. So in my private office, I just have my desk shaped. It's kind of, you know, a U-shaped thing. In fact, you see the photo right there. My patient sits across from me. They come in. My staff's already introduced themselves to them. We've greeted them when they come in the front door. We've offered them coffee or tea. And then they're just escorted into my room. I get up, I greet them. Thank you for being here. Thrilled to meet you. Mention originally why they came. And then we sit down, we just talk. So what brought you in today? What can I do for you? And it's just a conversation. And the interesting thing about that is, Kirk, is that they've never had that done. This is a new dental experience for them. They're used to going into the operatory and laying back and saying, and we're, you know, just writing things down. Right. This is the initial connection. This is the trust issue. And we're just having a conversation. And as they talk, we're allowed now to ask questions. And there's so much that we can get just from that conversation before you've even gotten into the operatory. And now I don't want to prejudge or anything, but I can have a good idea whether somebody's symptomatic, they're asymptomatic. Maybe they've already seen 7 different dentists, you know, and I'm number 8 for a treatment plan. So you get a lot of information. Again, we have some questions that we want in this checklist, you know, in this part that we go through. Okay. If you don't have the ability to do it in your office, you could do this in your operatory. And what I would recommend for that is don't lay the patient back. Right. Have the patient in an upright position. You can sit on your doctor's stool in front of the patient, so we're at eye level, you know, eye-to-eye contact, and do the same thing in your operatory if you don't have, you know, space. You don't need to build a room to do this, you know. Right. So, you know, dose of reality. You can do it in the op, just don't lay the patient back. Yeah. You know, that conversation is key.
Yeah. How long typically is a preclinical, and are you doing most of the questions? And how much does a team member play a role in that when it comes to preclinical?
I'll do it all myself because I
Okay.
really want to connect with the patient then. I'll have had, we send the dental history, the medical history, that sort of stuff. That's been gone over. I have that, and I'll get to that eventually, just to review it. So we've had that team member contact. But this part, I just want to connect with the patient. Now, I've been doing this, longer. So when you first start out, some of the patients are going to come in and it's like, hey, everything's fine, just need a cleaning, move, my old dentist retired, whatever it is. That's okay. You're still getting a connection with the patient. But the other thing, Kirk, sometimes like, people don't know to ask, you know what, my teeth are wearing away. I don't know what's going on. They only know that what they're used to is calling and saying, I need a new dentist. I need a cleaning. Right? So this kind of slows down that process down a little bit. The other thing it gives us the ability, and if that slide was still up or whatever else, is I just have a flat screen in my office here, and I have stuff like ready to go.
Right.
So animations and whatnot, things I've put together. So if they mention something, I get to show normal, and this could be perio as well, or wear, or facial pain, aesthetic issues, whatever it is. I can show how some of this stuff happens. So it lets me show normal, again, connecting with the patient. I don't know what I'm doing yet, but then when we go back to the operatory, these are some of the things that we're going to look for. So again, it just starts that process.
Absolutely. So after you finish the preclinical, a lot of times are you taking notes on a sheet of paper that you have, which is your checklist, or okay.
So we've kind of changed over the years to, we've kind of gone from the analog, everything on paper, and we still have that. We have all these forms, everything else on paper, but we've gone digital, and with what we kind of created called the Dawson Diagnostic Wizard. So the cool thing about it, again, now take everything I say about the Wizard with a grain of salt, because John and I designed this thing.
Okay.
But the reason that we did this, though, after doing this for a number of years, here's the deal. So any doctor that wants to go through and really create change, like looks at this and say, this is a great way to practice, or I know some of my patients need this kind of dentistry. If you're going to take the time and the expense to go through the process of learning how to do this, and honestly, all of this is learnable. I've been doing this for a while, but listen, I was nothing special. If I can do it, anybody can do it. Here's the key. You got to implement it.
Right.
Listen, there's a lot of us. Listen, dentists are fantastic on continuing ed. Everybody I know takes continuing ed courses, and that's all great. But small courses, great intellectual knowledge, but unless you have something to put into play to change how you're going to practice, to change the quality of care we provide for our patients, it's not worth it. So it's the implementation part that's important. So the reason for the Wizard is we had a lot of doctors that would go through our courses, and Pete had this too, and Glenn and Whit, they were the guys that taught me. But we had a lot of doctors that would go through, but they struggled with getting back to their office and put it in play.
Right.
Now, as I said, I did it, but I was so frustrated that I would just keep banging my head against the wall until I got it right. We don't want everybody else to have to bang their head against the wall like that. So what the Wizard is from the beginning to the end, everything you need is in one place. And it just totally simplifies the entire process and also cuts time off of everything. But the Wizard, the examination I'm going to talk about is in the Wizard. So actually, when I go through it, I do my preclinical notes while I'm sitting here with the patient. So I'm not the world's best typer, but I will just write in my preclinical notes. I've got it. Then we take the patient back to the operatory. We're going to do the exam, and the Wizard's up. And so page by page, now we have my assistant, myself, and the patient. We form what I kind of call as the triangle, with the patient at the head of the triangle. Yeah. So they can see me and they can see their assistant. We're not coming at them from behind.
Wait, can you pause right there? Because that is so awesome. Why do you do that? I want to know why.
Well, listen, patients can be a little uncomfortable in the dental office.
Right.
And if we're kind of flying around behind them and we're talking and they don't know what's happening and who knows what we're going to come in with, if we're in front of them, they are part of this process. Again, I mentioned that co-diagnostic process. We want the patients to be part of this. We're doing this together. I'm going to do a real thorough exam here. I'm going to tell you what we're doing. And this is atraumatic. There's nothing here for you to worry about. But they can see us so they know what's going on.
Yeah.
And they're awesome. The top. They're the top of the triangle.
Yeah. And that's a key piece because a lot of you know this, if you're watching this, a lot of times information gets vomited over the head of the patient to the doctor. Yeah. And you have to find a way now more than ever to completely differentiate yourself from every other dental experience that they've ever had. And what a great opportunity that they can process in front of you. So keep going. This is great.
So what you just said is huge because honestly, one of the things that you want is we want the patients that come through our doctors that are doing this, you want it to be different than any other dental experience that they've ever had, right? And I will tell you that routinely, this is what I hear from patients that I do this on, what we hear from doctors that start implementing this, is when we're done, the patients say, thank you. This was the most thorough examination I've ever had. I really appreciate you taking the time to do this, whether they have issues or not. Like, I'm fine going through this whole process, and at the end of it, they don't need anything. You know what? I'm okay. And I'm not kicking them out of my practice. That's fine. They're going to go into that general patient population. We're still going to take care of them. They're going to come in regularly for the hygiene. And I know I don't have to get all this other information that I generally get with our quote-unquote specialty patients. Right. I'm okay with that. That's fine. But here's the thing. I know they're a general patient because I've done the examination and I've interpreted the examination. So I'm not just winging it and saying, they don't need anything or they won't do anything. You know, so if something happens to them later, they could still end up needing some dentistry. They might need a crown on something. And if I have CIRAC or a millie in my office, I can just knock that out right away. That's fine. But I know I'm doing the right thing. It's those patients that we start doing that on that actually aren't that general patient. They have signs and implications, and it might be early in the process. But doing the dentistry on them could lead to less ideal results or failures, which is what we don't want.
Right. And as you can see, it's a classification system. Some people are a little bit in the fast lane, and others you just want to move them to a little bit of slower lane and nurture them along. This is great.
Absolutely. You know, and then we kind of talk about, the next slide, I'm going to say kind of 4 buckets of problems that people can run into. And, this is changing, and it will continue to change.
Right.
When I got out of dental school, and I think generally what they teach in dental school, it's the bacteria bucket, decay, gum disease, that sort of. And, hey, listen, we all got that down. They do a great job of teaching that. Every dentist out there has that. We're going to do perio probings. We're going to control the perio. If there's issues, we're going to get you to a periodontist. We're going to control infection, endo. You got decay, we're going to take care of it. That's the one, and that's how I practiced for a while. But that won't cover all of the problems on some of our patients.
Right.
So that's my next bucket. Then one is what I'm going to say is the functional based issue, and it can be tooth issues, non-bacteria, muscles, and joints. And that's what I got through the Dawson Academy. That's what I got from Pete, and then Glenn and Whit were my instructors, and that's what I struggled to put in play. And that took about, for some patients, how this whole masticatory system is set up is really important for some patients, because if it's not working for some, they're going to wear things out prematurely, or muscle pain, joint issues, those are the problems we're going to see with them. And that was great for a while. And then, the aesthetic boom in the late 90s, so, I've always kind of said Pete Dawson is like one of the originators of aesthetic dentistry. It's just that nobody knew it. Because when you really get into it, and he started talking about function in anterior teeth, especially the centrals, there was a reason for every dimension on that tooth, facial, incisal, lingual, cingulum, everything. And once you have that figured out, we determine in space then where that tooth should be for that patient, aesthetically and functionally. The aesthetic part then was, now how can we take that in space we figured out where that should be for that patient? And it's unique to every patient. That's unique. You can't just take a smile off the wall and stick it on our patients. We've got to determine those factors and where that should be. And once we've done that, hey, let's make them pretty. Let's make them look natural. And that's that global macro and micro aesthetics. I got AACD and I did this continuum years ago at LSU, had this fabulous continuum that I went through. And that was great. And that's how we went for a long time. But most recent, the one that's now everybody's talking about, we're thinking about, and you had Whit on, about a month ago, which was fantastic. It's Airway. Yep. Now we're seeing so many issues that we're going to pick up as dentists with airway that aren't going to get picked up on the medical side. You know, we're going to see some of this first. Wear and tear that we were originally thinking was maybe habit related or parafunction. Well, what's the cause? Well, for some of these patients, it can be secondary to an airway issue. Right. So now we have to start looking at airway. And airway trumps everything else we're doing. And what I mean by that is our patients need to breathe. Like this ends up being life and death stuff. Stroke, heart attack, blood pressure, you know, everything else. You know, apnea can be really, really serious. So we need to be screening for that and then get those patients, even if we don't want to treat it, and that's okay. There's all kinds of things we can do or not do. But if we identify it, then you got to get them to the proper people to take care of that problem. And that's before we start getting involved in extensive dentist stuff, you know, dental problems, I mean. So again, all of those things come through the exam. Yeah. So how do you pick, you know, of those 4 buckets? I think that's a lot there.
Yeah.
You know?
Well, a lot of times too, I mean, you talk about even something like oral cancer screening. You've known this for a long time. You can really be a hero to some of these patients because there's nobody that's that intimate to some of these human beings than a dentist is. And when you really slow the process down and identify airway challenges, you're talking about saving people's lives.
Absolutely.
And you're creating an incredible situation where people have to have you in their lives. So this isn't about how cheap you are or how fast you are or what great dentistry. I mean, you're becoming a significant person in their longevity.
Yeah. Kurt, the days of the dentist being just that tooth doctor are gone. Right. You know, I think it's our ethical responsibility to take the time to look at all these issues for a patient. And listen, if nothing's there, great. But if they are there, we need to get them to the appropriate people to take care of these. And whether that's an airway issue or somebody with oral facial pain, you know, that TMD patient, that's a whole other Pandora's box we can talk about at some point. But when you start doing examinations, you're going to see these patients, you know. And the amazing thing is, and the scary thing I think sometimes, Kurt, is that you're going to see these patients and they've been in your practice for a long time. Right. It's just that we never took the time to look at it before.
Yeah. Can I ask you a question? Because I consider you a master, and obviously you're looking at this through really unique lenses. But what percentage of your patients have airway challenges of when you look at those 4 buckets? Just throw a number at me.
So it's hard to come up with a number because my practice is a little skewed now. And here's what I mean by that. You know, as you start doing this, we're going to say, we want you to be the go-to dentist in your area. We want you to be we want patients seeking you out because you can solve problems different than other people. And my practice has evolved over the years with that. Probably about 80 to 85% of my new patients that I see are, for lack of a better term, TMD patients.
TMD. Okay.
Now, with those, now that I'm screening better for airway, probably half of them have airway issues.
Wow.
You know,
what about
less than half? But 50% would be the high end, but a lot more.
That's pretty high. Yeah. Wow. So of the TMD patients, okay, and I don't want to get too far in the weeds, but I want to get some perspective. How many of them aesthetically would you say percentage, or aesthetic fall in the aesthetic bucket? All of them? Most of them?
Most of them. Because by the time I get them, they've torn up their dentition.
Right. Okay.
You know what I mean? So they'll come in, hey, I want to look better. But you know what? They've got functional issues. They got, I'll say broad term, they're symptomatic. They got some kind of oral facial pain coming on. And maybe they have airway issues. And so we have to have the ability to look at what is the cause. Why is this happening for somebody that's 50 years old? Right. You know, why are their teeth wearing out now? They're not going to get another 10 years with this set of teeth that they have. Mm-hmm. So it makes maybe finding the answers a little bit more complicated. But again, once you look for it, and it all starts with the exam. You know, if you don't look for it and find it and talk to the patient and then get the right records, you don't know how to solve it. Right. So, and again, you know what? The pathway is still the same, whether it's the functional, the aesthetic, the airway, the symptomatic patient. The pathway is still the same. Right. We might have to do separate things on some of those patients, but the pathway is still the same thing.
Right.
Which is kind of the beauty of this. You know, I mean, in a sense, it's timeless. We've been building basically on Pete's core philosophy as all of these things has changed over time.
Right.
But that core philosophy and way to take care of the patients, that's not changing. We're just adding other layers on top of that.
Right. Well, the one thing that you teach that I love, or there's many things, is the predictability piece. And can you imagine if you didn't have a process, you would be making it up every single time. And that's too much brain space. I think it's really great when you have a methodical way to say, hey, look, I'm going to take great care of this person. And I'm going to do it the right way.
Yeah. Well, and the methodical part is the next slide. So this fourth slide. And just in a nutshell, this is just all the stuff we're adding to the exam.
Okay.
So these are the pages straight out of the wizard. We're not asking you to, kind of reinvent the wheel here. Again, what you're doing is for patients that you think need it. Again, we talked about that a little bit ago. However you want to do this in your practice. But for the patients that need a different way, you got to get this info. And honestly, these are just the extra pages. So this is the functional and the TMJ exam and the Airway. We have Airway in here as well. It's just the screening tool. You go through each page. My assistant prompts me, and we got that triangle going on. She prompts me. I explain to the patient what I'm doing and check in. Hey, it's an easy thing to say. You know what? One of the things we really look for nowadays is Airway, because we found that a lot of people that are having problems wearing out their teeth prematurely, it's secondary to an airway issue. So there are a couple screening things we're going to go through that they're just going to kind of give us an idea. Is that a potential problem for you or not? Right. You say it like that sometimes, and all of a sudden people will say, oh, yeah, you know what? I had a sleep test. They gave me a CPAP and I don't use it. Even though you've gone through the dental history, it's amazing what people leave out sometimes.
Right.
You've gone through that medical history. They say nothing. So, but that's kind of the dialogue. And now, again, we're being their advocate for health. We're not selling anything. I'm not trying to sell dentistry. We're trying to find problems. What are the implications if it's not taken care of? Gosh, Airway, that's life and death. That's an easy one. And then we're trying to come up with solutions. I'm here to help you if you want me to help you. But these problems are yours. Like you got to let the patient own their issues.
Right. Now, the key word you used is problems. You're not into the solution phase at all yet. And that's what a lot of young dentists do. They're quick to the solution. Yeah. What have you learned over time about this whole process? Is to slow down. Slow down. Interesting is a number of years ago, and this is actually one of the cases that we have in our hands-on courses. But I had a patient, Andrea, and she came in. She came into me referred from another one of my patients who just had some restorative work. Perfect way that we want to see new patients, right? Mm-hmm. So Andrea came in, and you know what, Kurt? She didn't want to be in my office. Mm-hmm. She was only coming because her friend said, you got to go see Drew. Okay. So she sat down. I do everything you and I were talking. Preclinical interview. She sits down. I said, Andrea, really nice to meet you. What's going on? Why are you here? And here was the first thing she said to me. She said, I have seen 13 of the best dentists on the East Coast to try to solve my problems. Well, I'm thinking, all right, I guess I'm not top 13. At best, I'm 14. Right.
So she says, what can you do for me that they can't?
Right.
And I said, I don't really know. Because I don't know what your issues are. I'm happy to sit and talk with you some. I'm happy to do an examination. We can chat a little bit after that. And then if there's something you want me to do, listen, I'm here for you. So we sat and we chatted for a while. And you asked how long for the preclinical. Here's what I've learned. 10 minutes, 15 minutes, normal.
Okay.
As I start to see TMD patients, I actually add an extra half hour. And I've learned the hard way because I always used to be running overtime. Because the symptom, and again, I hate that term TMD, but I'm going to say the symptomatic or the oral facial pain patient, their story is going to take half hour. Mm-hmm. They've been around the block. They've seen multiple dentists. They've seen physicians. They've seen neurologists. They've been on medications. They've got a baggie full of 13 different types of splints, so you get the. I had a woman one time coming with a binder that must have been 100 pages of stuff. She was talking about diseases I've never heard of in my life.
So you referred her out, didn't you?
Yeah.
I mean, but you got to be ready for that stuff at your level. Yeah.
So anyway, so here the end run on Andrea is we slowed it down. She let us do the records. I treated her. Okay. So at the end of this, and it was a long process because she was a symptomatic patient. She had been in an auto accident and things. So at the end of this, though, so I said, Andrea, so why me? You know, you'd seen 13 of the top people on the East Coast, you said, so why me? And she said, you're the only one that didn't tell me what I needed to have done right off the bat. You're the only one that took the time to actually look and to listen to what I had to say. And I think that just sums it up right there.
Yep.
You know, that's it. That's the reason we do it this way. And I think it's the right way to do it.
Right.
You know, I don't know the solutions when I first see somebody like that. I can look and identify problems, but I don't know how did they get there. I need more information to answer those questions. That's all we're doing. I mean, this isn't rocket science, you know. But those pages in that exam are super important for you to start to figure out, is this patient, you know, do they have functional issues? Do they have aesthetic issues? How are the joints? You know, can we proceed? Can they breathe? We need to answer all of these questions. You know, Pete talks about us being the physician of the masticatory system. I mean, he said that for years. Yep. And you know what? Again, you know, I heard this 25 years ago. Wow, is it getting more important as time has gone on? I mean, the tie-in with what's going on in our mouths with our systemic health, bacteria, heart disease, blood pressure, diabetes, and now the airway thing. There's no separating that the masticatory system is part of the body and part of the overall health for our patients. And it's our job to be the ones to screen for those, in addition to dentally related issues.
Yeah. I tell teams this all the time, and dentists, you have to believe that money spent in your office, number one, is some of the best money people could ever invest. And number two, this hole that's under their nose, about 70% of their health is related to what's going on here. And you see it all the time. So what a greater place to be in the which in dentistry, again, ranked the #1 profession in the United States. So every once in a while, a dentist has just got to pause and go, I have a pretty cool job. Like, this is a pretty good thing I jumped into.
Absolutely. And you know what? And if you can slow it down a little bit, it's even better.
Right.
You know, and listen, you know, for a while when I got out of school, I thought it was really cool to see 30 some patients a day. Like, I'm really working now. You know, this is great. All right. I got older, you know, after a while. That's a tough schedule, you know, and literally, you know, dentistry can be hard. I mean, physically hard. You know, you're up, you're running, you're bent over. We're looking in a small area. It's constricted. Patients don't always want to be there. I mean, it can be physically and mentally challenging, you know. Right. So, but what I found with this kind of dentistry, I think it's been a lot better on me. It's more enjoyable. I don't have to see those 30 patients, you know, a day. Again, I think it's important. We're not saying that there's anything wrong with that. If that's how you want to run your practice, that is perfectly A-okay. But then you maybe need to stay away from some of these specialty patients that you could get in trouble with if you kind of do the usual, customary, reasonable on that patient, if that makes sense.
Absolutely.
So the other thing, so if you take the time to do this exam, here's the next thing we kind of ask of the doctors. There's really 4 things that have to happen if you take the time to do the exam. Now, again, you've done the preclinical, you've connected with your patient, you're there to solve their problems, you've done this co-diagnostic process. But at the end of it, you got to do a couple things. And that's the first one is on the next slide. And it's the summary. So if you do the exam, then you got to sit down and interpret, what does the data tell you? You know, are there issues? Are there bacterial issues? Are there functional issues? Are there aesthetic issues that they want solved? And are there airway issues? You know, so what is that pointing to? So you got to summarize that. And then the next slide, and this is, you know, again, how we've changed a little bit over time. The next slide then is, the next thing that you got to answer is, can the patient breathe?
Right.
You know, with their setup, their face, their architecture, can that patient breathe? And if they can't, we got to get them to the right place. There's lots of people who are smarter than I am that can kind of take you through the protocol to deal with an airway patient. If you want to get involved in it, do. But again, there's a pathway and a set of protocols to follow through. I'll be honest, I was really kind of reluctant for a while to deal with the airway patients because I had enough going on. But honestly, after hearing more and listening to Whit, he had this, he did a symposium that he's doing for the Dawson Academy now once a year. Kind of, you got the mini version of what you talked with Whit about, you know, about a month ago. We can't avoid it. You know, we can't avoid it. So you know what? We got to deal with it. So I've set up the protocols in my office on how I can do it. And again, there's lots of ways of doing it. And but we got to get involved, at least at the screening process, and get them off. But that's the first big thing: is can they breathe? The next thing is the next slide, the 7th slide, is what's the joint health? And again, this is something Pete's been talking about for a long time. And I practiced dentistry for a long time. I never worried about that, you know, but it's huge. Now, you know, is it a normal, healthy joint? Great. That means we don't have to worry about it. We can go on and do whatever we need to do. And you know what? The majority of our patients, the joint's okay. But it's kind of like the airway. As you start looking for issues, not trying to cause issues, but looking for things that are already out, we're going to start to identify patients that have something going on in the joint.
Right.
And it's either a joint that's maybe starting to cause problems, or the patient's symptomatic. So you're getting occlusal muscle issues, can be sore muscles, facial pain, joints breaking down, cartilage is coming out of place. Or maybe it was a patient that had more elaborate problems, but you've treated that and now they're stable, something Pete's called adapted centric posture. So they had problematic joints, but you've treated the joints. Whatever we did, you've treated the joints. And those patients, you know, we call that type 2 patient, you know, a yellow patient. Right. Our goal with them is those are the ones that we're kind of taking through this process. They're the ones that we kind of want to set up and deal with their functional issues, their aesthetic issues, and to do it, we need more information. The third kind of category is what we say is the red joint. And that's somebody they got a complete disc dislocation, or they got degenerative joint disease. The bone is breaking down, or they're on that living tissue. They're uncomfortable. Or they have a very unstable bite. Because if things are changing dimensionally at the jaw joint, bones are changing, that means that the bite is changing. And so if we were to do restorations, whatever it was, and it's not stable, you come back later, it's not going to be the same. Or you got wear and tear going on. Yeah. So again, it's part of our protocol. If it's the red joint, you got to treat the joints first, and there are ways of doing it. You know,
right.
Ways of doing it.
And I want to pause right there too, because a lot of times in traditional education, even the education you're seeing going on right now, one of the things you guys are big fans of is managing the forces. Because I mentioned this with John, we were talking yesterday, you can create gorgeous dentistry, but the chances of these patients living longer is increasing. And so I don't care how beautiful this is, you put the wrong forces, it's going to wear, and it's going to fail, right?
Yeah, listen, we're sticking glass all over the place now, aren't we? You know, and it's not, and glass is not enamel. You know, we don't have a material that replicates natural enamel yet. So we can make stronger things, we can make more aesthetic things, you know, so materials ends up being huge. But what we ask that material to do is really an important issue. So if we can set up that function right, and again, for that second category, that patient that we're going to take through this, part of our design process is to set up the function right so that things aren't going to continue to break down. If we do restorations, the things that led to the teeth getting compromised to start with, we don't want that to happen to our restorations. So controlling the forces is huge. Yeah. And then identifying a patient that we shouldn't treat yet because they got something else going on.
Right. Right. Now, once you do the classification in the joint, you actually classify the types of patients. You have a green, a yellow, and a red. Yeah. Can you talk about that and how that works?
Yeah, and that's kind of the last question that we answer after this examination. So if that's up the next slide. So I'm going to kind of 3 patient types, and so this generalization. So you go through the examination, they can breathe, the joints are okay. They don't have any signs and symptoms of problems. That's what I'm going to call that general patient again, that green patient. We don't need to do the other stuff I'm going to talk about in a couple minutes. Usual, customary, reasonable is fine, even if they need a little bit of dentistry, but that patient doesn't really need a lot. It doesn't mean they have a perfect function. It doesn't mean that they have, the 5 factors of stable occlusion that Pete's talked about forever. They could still have a hit and slide. They could still have some interferences if you go into excursive movements. But for whatever reason, they're not playing with their teeth enough to cause problems in tooth, muscle, or joint.
Okay.
So this isn't about trying to make every patient in the world have a perfect occlusion. It's trying to identify the ones that function could be cause a part of their problem.
Mm-hmm.
So that first category, those general patients, it's okay. Again, get them into hygiene, take care of the bacteriological issues. They don't need all this other stuff. That second category, what I'm going to say, is that yellow patient. That's the one that has signs of instability. So we've done the examination and we identify problems on the functional side. It could be muscles. It could be beginning stuff at joint. It could be wear and tear on teeth. Wear, mobility, migration, abfraction, sensitivity, all of those things that could be the non-bacteriological things that are signs of teeth are wearing out. Hey,
right.
Wear on teeth with exposed dentin, is that stable?
No.
I mean, those teeth are just going to break. Thanks for answering that. Teeth are just going to break down a lot faster now. But how often do we see patients with wear into the dentin, but it's not a bacteriological issue, so we as dentists don't do anything about it?
Right. I mean, and you can interpret value with the patients too and let them know you're at a point where now it's 5 to 7 times faster.
There you go.
And they get that.
Absolutely.
This is going to happen faster and faster and faster.
Absolutely. So that's really kind of that category that as this quote unquote Dawson dentist, that's what we love. Like your ideal patient, they have healthy joints and they're that yellow patient, they need dentistry and they want you to solve their problems.
Right.
That's kind of what I'm going to say is that's the wheelhouse for the patients you're identifying in your practice that need a different way of going. And man, you can those are great patients. You can really affect great change with them. You can really feel great about the dentistry you've done. And you're not selling a thing. You're helping solve their problems. Right. So the other category, that third category again, is those are the patients that got stuff going on in the joint, and they're uncomfortable. So they're that symptomatic TMD patient, whatever else. And we're not doing irreversible dentistry on them. We're not equilibrating. We're not doing ortho. We're not doing restorations. You got to try to get that patient asymptomatic. And our job as a dentist, we start talking about the TMD patient. I'm going off a little bit on a tangent, but it comes up when we talk about that category is the thing to remember with them is our role as a dentist. If we step back and look at them as an oral facial patient and from the shoulders up, there's a lot of stuff that can cause symptoms in the head and neck area. Mm-hmm. Part of it could be dentally related. Right. Our role as the dentist, honestly, is to figure out is all of the pain, some of the pain, or none of the pain a dental related issue. And if it is, we can deal with that. And if it isn't, again, other specialists on whatever your team is for the oral facial pain patients to get them onto.
Right.
So now, hey, listen, a lot of them do have dental issues that are the cause, and we can deal with those. But you got to remember, we're not trying, not every issue for an oral facial pain patient is a dentally related thing.
Right.
So we kind of like, if you look from the outside in, we'll generally have pretty good success with that. But you got to look, there's a lot of stuff that be going on there. And first, irreversible treatment. I mean, reversible treatment. We don't want to go in and try something you can't back away with. So we don't do irreversible dentistry on that patient until we've got them asymptomatic. Now, if they need dentistry, we're going to go through the same checks and protocols that we're talking about.
Mm-hmm.
Okay.
Awesome. Now, when we put all this together, the next one we can do, we're actually going to go into the treatment planning process because that's fun. I mean, what do you do with all this?
I know.
But what are some of the things that you've learned for sure? Maybe some pitfalls when you look at the exam and records process that you would say to a young 32-year-old dentist that's watching this?
Well, one is you don't do it.
Right.
You don't do it, or we get ahead of ourselves. Sometimes it's easy to identify that quote unquote specialty patient. You know what? They come in their mess. They got aesthetic stuff. They want you to solve their issues. And we got holes in our schedule and I want to fill that 4 hours I have next week. Mm-hmm. So let's get them in so I can do these upper anterior restorations. Probably the worst thing you can do because even if you do it, they could look beautiful, mm-hmm. but if the function's not right, it's a much higher chance of failure. Mm-hmm. So there's a reason for the process and it's following the process. And I'll say every patient, every time.
Right.
Where I've tended to get into trouble over my years of doing this is when I got too smart for myself. And I started skipping steps. And I'll tell you, almost every time I do that, you pay the price, you know? So there's a reason we laid everything out this way. And you go back decades of Pete's trial and error, you know, Whit and Glenn's trial and error, you know, John's trial, you know, things that we've learned over time that I think have just kind of made this process, what I'm going to say, is more predictable. You know?
Yeah, this is great. So again, any other thoughts that you have for young dentists watching this?
Yeah. Well, I guess back to kind of that pyramid thing that you talked about, you know, that that you shared with us, a triangle of success. You know, the bottom of that you talked about is their vision for life.
Right.
And so, and add the vision for your practice. So somehow, you know, you just got to get away from the office for a minute and sit down and think, what do I want for my life? Right. You know, in the big picture things. You know, we used to have this course called in fact, we're just bringing it out again, called the Top 10%. It was the first course I ever took. And I know you know that one. It's a great course.
Yeah.
And I went to that when I was just super frustrated. I mean, I was going to retire from dentistry, find another career, you know, because I can't do anything halfway. And I didn't feel like I was as good as I thought I was. That's always an interesting conversation with yourself. But I went to the top 10%, and it's not about being the top 10 producer in dentistry. It's about being the top 10 problem solver in dentistry and doing the things that we just talked about. And so the other thing, though, that they did is I heard Pete talk about not the nuances of the day-to-day dentistry, but how do you want your life to be? You know, back up. How many simple things that we just don't allow ourselves the chance to think about? How do you want to live your life? How many hours do you want to work a week? What's your vacation time? What do you want your hours to be? Dentistry is still this fantastic profession that we get to pick what we want to do. Now, obviously, you got to produce and make it happen. I mean, you're joking with me. I work 7 to 2, right? You know, but it took me a while to get that. But I decided, hey, I want to work 7 to 2. So let's see if we can make this happen, you know, 4 days a week. And it can, you know. So look, for a young dentist, I'd say, I know you got school loans. You might be looking at costs for more, you know, education that we're talking about. But back away and think, what do you want your life to be? And then fill in, how can I get there? And what do I want my practice to be? Do I want to be on roller skates 6 days a week from 8 in the morning to 5 at night? And if you're okay with that, it's okay, you know. But we also want you to see that there is another way to do it. There is a way to slow down a little bit. There is a way to solve different kinds of patients' problems. And that to do that, you can't see 30 patients in a day. No. You know, some days, Kirk, I might only see 4 or 5 patients. I've got what we call, we do primary care and secondary care. Primary care is where I do the longer restorative patients. Now, my practice is focused. I don't do any perio outside of, you know, scaling, root planing. I send it out. I don't do any endo. I don't do any surgery. I don't like blood in my office. I get great specialists to send that to. So my primary care is restorative dentistry, or the TMD patient that I'm doing things on. But that's like a 3-hour block of time. But it's normally more extensive dentistry. So 3 hours with that patient. And then the rest of my day could be a new patient exam. And then maybe what we call an occlusal analysis. That's the patient that we'll mention here before we're done. What are those records that we need to get? So it's getting those records. And then maybe my next patient is what I call a treatment option review, where the patient comes in and is like, okay, so we did the exam. You wanted me to solve your problems. We got the records. And I sat down over the last week or two, like I told you I would, and here's what I've mapped out. And so we talk about options at that point.
Yeah.
You know.
So it's beautiful how you said that. And think about this. If you're watching this, today's as young as you're ever going to be. Like today, this is it. Why not? Well, you know, like me, you wake up and you're like, oh my gosh, I can't believe how many years went by, you know? So these are critical decisions if you want to slow down. And really, it's a core values exercise. You just got to learn more about who you are as a dentist. You know, I can imagine your office is very slow pace, a lot of hugging going on, a lot of laughing, you know, and it's not good, bad, or different. You just got to choose how you want to practice.
That's it.
Yeah.
And the records part that we talk about, you know, which is the next slide, is, again, nothing earth shattering, but to figure out, to solve these problems, you got to get impressions mounted on the articulator. The whole reason for articulator is it's just a mechanical device that lets us look with something as close as we can to how the patient's actually functioning. That's the reason for the articulator. FACEBO, CR mounted models. CR is an easily learned process. We do it all the time. A lot of the courses, when we do this examined records course, it's hands-on. Doctors that haven't done this before, we do multiple records on multiple patients, each other. During this course, we're generally at a 95 plus success rate, pinpoint accuracy that we use as center check to make sure how we're doing. And you got to get photography. You can't do restorative dentistry anymore without photography. So we have a template, 12 AACD photos with, another 9 that we kind of refer to as functional photos. And if we have those, that allows us to start answering questions. The models is kind of the functional side. The photos is kind of the aesthetic side, and we marry all that stuff together. But if you don't have that info, you can't do it. Right. And then the last piece, and this is kind of the jumping forward thing a little bit too, is now you get all this, and and now what happens? Right. So and that part is treatment planning. One of the things I always heard from Pete that I always try to remember is, again, this isn't about selling dentistry. This is about us trying to find out what's the right and ethical thing to do for our patients. So how do we solve their functional aesthetic issues with the least amount of problems? And we treatment plan using the dentist idiom rule. Right. Would I do it on me? And that's always has to be on our mind. And you don't need a lot of stuff to do this. You need 2 sets of models, one that's the originals, one we can work on. You got the wizard. We have the 2D and the 3D treatment planning, and the wizard, it deals with the photos and everything else. And that's then where we start solving the issues for our patients. And one other thing, just to get this in before I get off, is fees always come into this.
Right.
I get it, because, and we always tend to think of this on the treatment planning side, so when we're done the Whittiam rule, what's it going to cost? Right. But you got to have that conversation during the records appointment. Like the earlier you can have this conversation with a patient, I think the better. Now, and I'd be interesting to think, what you tell your doctors and everything else. But and I've heard all kinds of stuff over the years. The doctor shouldn't present a case or talk about fees. Whatever turns you on. But I don't have any problem doing it. But what I want to know early on is, and I kind of get this a little bit because John would say this to his patients. He said, is there anything that's going to prevent you from getting the kind and care of dentistry that we think you deserve? Let me know now. Because when I sit down and work things out, I'll try to come up with a plan that best suits your needs. My gosh, that's a really simple thing to say. I'm being your advocate for health. And tell me, time or money, because some of these things can be expensive. Well, how expensive, doctor? Well, you know what? Gosh, it could be, some of these things sometimes could be tens of thousands of dollars. And they say, wow, gosh, I could only afford $10,000. Well, you're not going to give them a $25,000 treatment plan if they can't afford it, right? But there's all kinds of ways when we get into treatment planning that we can phase treatment. That's the other thing. You still got to come up with what's the right ideal, but that doesn't mean and some of these patients need extensive dentistry, but it doesn't mean you have to do it all at once. Composite now lets us do interim restorations that can last for the long term, but let us spread costs out. But where teeth go aesthetically and functionally, that doesn't change. We might just be using different materials in space to get us there. But I want to know that now. So when I actually do that treatment option review with the patient, I'm going to break it up in segments of $10,000 if I can, within the patient's budget. And ask me how I know. I learned the hard way.
Yeah. Well, there's beautiful wisdom. If you're watching this, there's beautiful wisdom in that question because you're proactively bringing any challenges the patient has to the surface instead of trying to deal with them later. And that's the beauty in this. And it also says, I care a lot. Yeah. So beautiful work, Drew.
And that's the trust factor. Again, that's the trust that starts, for treatment planning, it starts at the exam. It starts how we first meet that patient.
Yeah. And so, I've heard you say this before, when you do this, all the other stuff is easy. So, so now you can actually put the pieces of the puzzle. Now you have the box and the picture and all the corner pieces. Yeah. Sometimes when people put the puzzle together, they only have like a few little pieces. Now you got everything. So we're going to be talking about that in our next session. And so if you're watching this, please add questions to the feed, either on this particular episode for Drew or on the upcoming episode for Drew, because again, we want you to get the most out of this. Now, Drew, if I'm watching this and I'm a young dentist and I'm just overwhelmed and I'm like, or even a mature dentist, like, okay, that's so easy for you to say, but where do I start? You guys actually have courses. You've got Seminar 1. Yeah. And we said this before, Seminar 1 is in person. I'm going to see you on Friday in Chicago. Yeah. But you can also do this online. It's too easy not to do, right?
Exactly. So if this makes sense to you, you want to try to practice a different way. You want to provide better care for those specialty patients. You're going to need more than we can give you in a webinar. So you got to take a class. And so, so Seminar 1 is kind of the overview of the philosophy of everything we've talked about, but expanded upon, a lot more detail. And that's kind of getting the philosophy down. And you can do that in person. Yeah, right. It's in Chicago this weekend. There's others that are going to be, a lot of them kind of based out of Florida. We still do it down there a lot. Or it is online now. So, for the young dentists that are so used to looking at things online, you can sit in the privacy of your home and watch the seminar. So contact the Dawson Academy. They'll have all the particulars for you about, how to do that.
Yeah, and I'm just going to speak from someone who has kids at home. As much as you want to watch this stuff online, it's better sometimes just get on a plane and get away from everybody so that you can focus and come back. And so don't hesitate. You don't have the money you can't afford not to do this. You've heard that 800 times. So
exactly.
Drew, I'm crazy, crazy grateful. If people want to get a hold of you, how can we get a hold of you if we have questions?
Get a hold of me through you or through the Dawson Academy. Happy to answer questions, anytime we can. We do that all the time. So if I can help you any way, change your life as a dentist, that's what it's all about.
It is, buddy. So awesome. Crazy grateful that you're sharing your wisdom. And I've got tons of notes, got a lot of work to do here. So stay on for just a second while we say goodbye to everybody else. But thank you guys for watching. We really appreciate it. Got quite a few people watching today. If you found this particular episode valuable, do me a huge favor and just hit the share button, because we'd obviously love for you to share it with all of your friends. And keep sending us suggestions that you either want to hear from Drew or anyone else, and we'll make sure that we make that happen. So until we see you next time, keep watching the Best Practice Show. Thank you, guys.
Thanks so much.